Good afternoon, everybody. As you all know me, I'm Gavin Giovannoni. I'm the academic lead for the MS Academy, and I would like to welcome Matthew Walker, our speaker tonight, who is a good friend, to address this important emerging topic. I shouldn't say emerging topic, but under-recognized topic in multiple sclerosis patients. I'd also like to thank our sponsors, Roche and Celgene, which is now part of Bristol Myers Squibb, for the sponsorship to allow our COVID-19 related webinar series to continue. I think most people who work in the UK know Matthew very well. He's a consultant neurologist at the National Hospital at Queen Square, and he spends his time working on mechanisms in epilepsy, but also runs the sleep laboratory. And unfortunately, his colleague Sophia Eriksson was unable to present tonight for medical reasons. And so Matthew is going to give her talk. I must be honest with you now, when I actually see people in my clinic, I include in everybody a quick sleep screen. And I've picked up, I can't tell you how many people I've picked up with treatable sleep disorders in the last 2 years since I became acutely aware of this problem. So Matthew, it's over to you, and thank you very much for agreeing to do this webinar. We appreciate it.
Right, well, thank you very much, and it's a pleasure to be doing this. And it's a pleasure in many ways, not least because, strange enough, I see very few referrals of people with multiple sclerosis. And yes, I know that there are many people out there with multiple sclerosis who have significant sleep problems. Unfortunately, Sophia couldn't be here. So I'm giving two talks, mine and hers, and my talk is going to be more of a general talk just about sleep itself, why it's important, about the frequency of sleep disorders and the sort of sleep disorders you see in multiple sclerosis. And then Sophia's is going to be much more of a practical talk about how you identify people, how you can start treatment, or what sort of treatments you can consider, and then talk about investigations as well. And so hopefully by the end, you'll have an idea of the severity of the problem, the magnitude of the problem, and how to address it. So during my talk, I'm going to talk about sleep physiology and sleep deprivation, about sleep disorders and MS and just how common they are, and a bit about why sleep disorders are more prevalent in MS. So sleep is something that all animals need. And for whatever reason, we seem to require different amounts of it. So from giraffes who just need a couple of hours at night to some bats who need 23 hours of sleep. And you can see there as humans, we sort of lie slightly in the middle. And it's always been a big question as to why we require sleep and what sleep is for. And I have to say, it's only partly solved. We know what the effects of sleep deprivation are, but we don't always know quite why we go through different stages of sleep and what precisely those stages of sleep or why those stages of sleep are relevant. Now, I think we can start off with what is a normal amount of sleep. And people always say, oh, it varies from person to person. In fact, there's not that much variation. So most of us require about 7.5 hours to 8 hours of sleep a night. And that's across all countries. This is in fact from a survey across a number of different countries. And the amount of sleep that people require seem to be fairly consistent. And most people go to bed around about 11 and get up around about 6 o'clock. And it takes a significant amount of time for people to get to sleep, usually about 20 minutes. And if people are worried about lying in bed, you can tell them it takes people about 20 minutes to fall asleep. The interesting thing is when you look in most surveys, a high percentage of people have naps. This is true across all nations. This is true in the UK, that about 20% of people will have regular naps during the day. Rather indicates that perhaps we're not getting enough sleep at night. And during sleep, we go through two dominant stages of sleep, which is the non-REM sleep and the REM, the rapid eye movement sleep. And the non-REM sleep used to be divided into 4 categories. It's now divided into 3. And the first one, N1, is just light sleep, just as you're dropping off. So you just lose the normal background rhythms, your eyes start to roll. You'll be aware of what's going on around you outside. And then you get into stage 2 sleep, and stage 2 sleep, as I'll come to later on, is important because we have these things called K complexes, which you can see on the EEG, and often sleep spindles, which is sort of 14 hertz activity. You can see it a little bit here. And those may be important for memory consolidation. And then we get into deep sleep, which is stage N3, which tend to have high amplitude delta activity. And stage 3 is a sort of recuperative sleep. There's also a theory that stage 3 sleep may be necessary for sort of clearing toxins from the brain. And again, I'll come to that later on, and why deep sleep, stage 3 sleep, may be important. And then we have the rapid eye movement sleep, and this is a sleep in which everybody seems to be most familiar. This is an occulogram. You can see the rapid eye movements here. You can see that compared to the other stage of sleep, you tend to have rather sort of mixed frequencies in the EEG. You tend to be dreaming during this type of sleep. And so you don't act out the dreams. There's muscle atonia. And you can see if you watch your dogs or cats, or dogs, which most people now seem to possess, if you watch them when they're asleep, you can see them running and moving. And that's because they have a lot of this REM atonia and start acting out their dreams to a certain extent. But we have quite efficient muscle atonia, and so we don't tend to act out our dreams. And during the night, we tend to cycle through cycles that last about 90 minutes. We initially go, at the beginning, go to sleep. We tend to go through light sleep and then into deep sleep, into light sleep, into REM, and that tends to be a cycle. And then we go through light sleep, deep sleep, and so forth. And what you'll see over these 90-minute cycles on a hypnogram, as you move towards the morning to the 7 or 8 hours sleep, you can see the REM periods get longer and longer, so that by the morning, you're having long REM periods, and the deep sleep tends to become less and less. So by the second half of the night, you're not having any deep sleep at all, and it tends to be light sleep and REM sleep. And this is important for a number of reasons, one of which is that it means we're much more easily woken during the morning, whilst we tend to be much more deeply asleep at night. Also, if people have things that disrupt their sleep in the early part of the night, it will often disrupt their deep sleep, and deep sleep disruption can have a number of effects on the way that you feel during the day. And also things that tend to occur during deep sleep will occur in the first third of the night. So that's things like sleepwalking, night terrors, and things that happen during REM sleep, during the dream sleep, tend to occur towards the morning. And that's things like REM sleep behavioral disorder. So the time when things occur during the night is often a useful indicator of what those things may be. Seizures, which I'm particularly interested in, don't tend to occur during REM sleep. They occur during light and deep sleep, so they occur often throughout the night. So one of the questions is, what are the impacts of sleep deprivation? Why is sleep important? And I'm going to show you some data about sleepiness. I mean, one of the big problems about sleep deprivation is being sleepy during the day. And that has incredible impacts on performance, on quality of life. But there are other things that sleep can affect, sleep deprivation, memory and cognition. So memory formation and to some extent consolidation is important on sleep. There's problems with mood as well, that sleep seems to have an impact on mood, and sleep deprivation has an impact on mood. But there are other things as well, increased mortality and the effects on the immune system. And we'll come to that as well. So it's well known, if you don't get enough sleep, then you tend to be sleepy. And I think there's nothing that indicates that so well as car accidents. 20% of car accidents are due to people being sleepy. If you look at the time when car accidents occur, they tend to be occurring right in the middle of the night, 3, 4 in the morning. And if you look at this in red is the amount of traffic, and you can see that's when you have the lowest amount of traffic, but still the highest amount of accidents. When we have the highest amount of traffic during the day when people are awake, the number of accidents actually drops. And so really the number of accidents relates to more to our sleepiness than to the amount of traffic that there is around. And sleepiness, as I say, has an adverse effect on our performance during the day. So we know that sleepiness can affect frontal lobe function. So our ability to build IKEA furniture is much worse if we're sleep deprived. It affects our concentration. It affects memory. And it affects the encoding of memory, both that's declarative memory as well as procedural, so that sort of motor memory is affected by sleep deprivation in a negative way. Consolidation is affected as well. So there's good evidence for procedural memory. Declarative memory is less clear, but certainly memories tend to be less robust if you don't have sleep. So if you have sleep, they tend to be more easily disrupted or destroyed. And so it's important for retaining memories. Interestingly enough, sleep deprivation has no effect on retrieval. It just tends to slow retrieval because of concentration, but absolute measures of retrieval seem to be unaffected. So encoding and consolidation of memory is directly affected by sleep. And that's because the sort of sleep rhythms that we see, such as sleep spindles, K complexes, are important in a circuit that involves the hippocampus, thalamus, and the neocortex for the consolidation and encoding of memories. But something that's been of increasing interest over recent years has been the fact that sleep deprivation, and in particular deep sleep deprivation, is associated with amyloid and abnormal tau deposition. And this has been observed in animal models where you sleep deprive animals and see that there's an increase in beta amyloid and tau, but also more recently there have been studies in humans and healthy humans, and these are people who are deprived of deep sleep. And if you look at with acute sleep deprivation, and these are CSF, so that should say CSF levels, this is slow wave sleep suppression. So you're suppressing the slow wave sleep. The absolute amount of sleep is similar, but the slow wave sleep is decreased, and the CSF levels of beta amyloid shoot up. Interestingly enough, the phosphorylated tau doesn't seem to change. However, with chronic sleep deprivation over a week, both the beta amyloid and the tau go up in the CSF, and there's increasing evidence that amyloid deposition, phosphorylated tau deposition may be related to chronic lacks of deep sleep, and that they may promote cognitive decline in people in the longer term. There's some epidemiological evidence as well to show that people who have sleep deprivation, this is very recent, also tend to have worse performance on mini mental test scores. So we have sleep making us sleepy, affecting memory and cognition, but also sleep has a profound effect on mood. And there's a whole host of papers I could have chosen. I like this one mainly because it's just a sleep deprivation over a period of 24 hours, looking at adolescents, and I'm sure many of us have experienced this if you have adolescent children. But you start to get to the time they should go to bed, and they're not going to bed, and they're staying up at this sort of time, which they often do. And obviously they fatigue, that's something, and the vigor goes down. That tends to be what occurs with sleep deprivation. Confusion goes up as well. People become more muddled, but also there's quite marked increases in anxiety, in depression, anger. And you can see this both with acute, just missing a night's sleep, acute sleep deprivation, but also with chronic sleep deprivation. You can see all these indices going up. And sleep has a profound effect on our ability to cope with things that occur during the day. And of the two, anxiety is probably more greatly affected than is depression, but both of them are affected by sleep deprivation. So those are sort of things that it can have on our sort of mental well-being, but also there's increasing evidence that sleep deprivation increases mortality. And these have been big epidemiological studies. And the interesting studies are not the ones that just look at the amount that you sleep, because there's all sorts of things that may influence the amount you sleep. But those people, what happens to those people who change the amount they sleep? And what happens to their mortality rates? And if you decrease your sleep, the amount of sleep you have from 6, 7, or 8 hours, and you decrease the amount of sleep, then you increase your mortality rate. And this is corrected for things like alcohol consumption, physical activity, blood pressure, smoking, etc. Interestingly enough, the converse is also true, that if you increase the amount of sleep from a healthy 7 or 8 hours, you spend more time in bed, then your mortality goes up as well. But you tend to die from different things. So you tend to die from cardiovascular disease if you have too little sleep, and you tend to die from other things, non-cardiovascular disease, mostly tumors or cancers, if the amount of sleep goes up. And so one of the questions is, maybe increases in the amount of sleep that you need may be an early sign, for example, of a covert tumor that is not diagnosed at that stage. But that's not absolutely well known why that effect occurs. Certainly the decrease in sleep affects a number of different pathways, metabolic pathways, that seem to increase the risk of cardiovascular disease. It also increases weight as well. And in more recent years, there's been an increasing recognition that sleep is critical for our response, our immune response. We know that, for example, vaccinations, there's good evidence that if you sleep deprive people after vaccinations, you get less of an immune response than if you actually, people get adequate sleep. And that's been done in controlled studies. But also the other thing, the converse is also true, that inflammation itself, so it's a two-way street, inflammation itself has a considerable effect on sleep. So inflammatory mediators, interleukins and so forth, will increase total sleep time and total sleep efficiency. They tend to increase slow wave deep sleep and decrease the amount of REM sleep we have. So they tend to make people sleepy and increase the amount of sleepiness that they have. And we all recognize this. We know that if we have a viral illness or are unwell, that we feel sleepy and we sleep for longer. And there may be a reason for that, because certainly having adequate amounts of sleep or having increased amounts of sleep increases our antiviral immune response. So both in the interferon response genes, interleukins levels change, and that may well be a sort of positive feedback loop to try and increase our immune response to whatever is causing the immune reaction. And of course, the converse is true, that if you start to get sleep deprivation, then you start to have an adverse effect upon your immune response. And this has been investigated in a number of animal models, where if you sleep deprive animals for long enough, then they tend to be much more susceptible to infections. And there's also been some studies in the armed forces as well, demonstrating that there may be an increased susceptibility to various infections if you sleep deprive people over long periods of time. And indeed, there's been a very nice study not so long ago looking at what sleep deprivation does to our sort of immune gene expression. And this is looking at monogenic twins and comparing a short sleeper against a long sleeper in those genes. So it's a sort of direct comparison. And there's a whole host, I'm not going to go into this in any detail, there's a whole host of alterations in gene expression in immune cells that in the blood that would indicate that sleep deprivation or sleep differences, short versus long, can have a variety of effects on the immune system, generally with the short sleep having an adverse effect on the immune reaction, and longer sleepers, in fact, promoting the immune response. So that's a bit about the effects that sleep and sleep deprivation can have. And they do have profound effects upon our performance. And as I say, one of the things that I find in a way rather worrying is that I get referred very few people with multiple sclerosis. And yet we know that sleep disorders in people with multiple sclerosis are incredibly prevalent. So moderate to severe insomnia affects about 30% of people with multiple sclerosis. So these have been in large surveys that have been undertaken in people with multiple sclerosis. And you may say, how does that compare to the general population? The general population is about 10 to 20%. So it's more and significantly more than the general population. But certain other things seem to be of particular note. So about 40% seem to be at risk of obstructive sleep apnea. So this isn't actually measuring obstructive sleep apnea. This is using a questionnaire, which I'll come to in Sophia's talk. But it seems that a significant number of people with multiple sclerosis are at risk of obstructive sleep apnea. A large number of people have excessive daytime somnolence, 30%. And what you'll notice in these surveys is that many more people have fatigue than actually have excessive daytime somnolence. And it's important to separate out fatigue, which is a sort of lack of physical or mental energy, as opposed to daytime somnolence, which is wanting to fall asleep. They're interrelated, but they're not the same thing. But there are other things that are prevalent in people with multiple sclerosis that are worth asking for. So restless leg syndrome, it occurs in about 20% of people with multiple sclerosis, compared to about 4% in control subjects in this controlled study. And people with restless leg syndrome often have poorer quality of life and very disrupted sleep overnight. And then there are things that are directly related to lesions. These are rarer, but central sleep apnea can occur in people with multiple sclerosis, and indeed the increased sleep apnea that is seen in people with multiple sclerosis may be partly due to lesions in the brainstem, but also weight gain, and then also narcolepsy. Narcolepsy can occur with lesions in multiple sclerosis. It's rare, but it does occur, and it's worth, if you don't ask about daytime somnolence, you just won't pick that up. And this has a considerable effect on people with multiple sclerosis quality of life. So if you look at various quality of life scores, the FS36 here, compared to sleep quality, which is a measure, a Pittsburgh Sleep Quality Index, which is a good measure of sleep quality, and the higher is the poorer sleep quality, and you can see that there's a strong correlation with poorer quality of life. And so really, I think if you're not addressing these problems in people with multiple sclerosis, then you may be not addressing something that could in fact have a big impact on their quality of life. So what about mechanisms? Well, a number of different mechanisms. There's obviously indirect mechanisms that disrupt sleep in people with multiple sclerosis, such as pain, urinary frequency, getting up at night, anxiety and depression. Anxiety is probably one of the biggest drivers of sleep disruption in all people. Weight gain obviously predisposes to obstructive sleep apnea, and then medication. And obviously steroids can disrupt sleep, but some of the disease-modifying therapies that are used may well disrupt sleep through having an impact on the immune system, as I showed earlier on. And then there are more direct things that may impact upon sleep. So there's inflammation, and as I showed you, inflammation itself can have an effect on the amount of sleep that we require and how sleepy we are. I'll come to spinal cord disease. Spinal cord disease is associated with restless leg syndrome and periodic limb movements, so it may be related to that. But also the spinal cord disease may also be related to circadian rhythm, as I'll show you. And then brain lesions, and obviously brain lesions can have a significant impact on sleep, depending on where they are. So if you have brain lesions in the thalamus, you can get loss of your normal sleep architecture, you tend to get more disrupted and more fragmented sleep. If you have lesions in the brainstem, particularly in the pons, you can get sleep disordered breathing. The REM sleep behavioral disorders occur as well with lesions in the brainstem. And then if you have lesions, and I'll come to this obviously around the hypothalamus, then you can get circadian rhythm disorders, and also the hypothalamus has an important role in determining our sleep-wake switch, and so you can get hypersomnolence or even insomnia, depending on whether the anterior hypothalamus, which tends to be a sleep-promoting part, so anterior hypothalamus involvement tends to give people terrible insomnia, and involvement of the posterior or body of the hypothalamus tends to cause hypersomnolence. And circadian rhythm, and in fact, it's quite interesting, there's very little literature on this. So I think it would be worthwhile studying circadian rhythm disorders in people with multiple sclerosis. There's a whole host of areas where the circadian rhythm can be disrupted. The circadian rhythm is driven mainly by these particular melanopsin expressing retinal ganglion cells. And there's a specific tract that runs with the optic tract, which is the retinal hypothalamic tract that goes directly to the suprachiasmatic nucleus that regulates our circadian rhythm, day-night cycle. We also have melatonin release from the pineal, but in fact, what drives that is a circuit that goes all the way down from the hypothalamus down into the upper cervical cord, and there from the superior cervical ganglion back up to actually affect melatonin release through the pineal. And it's known, certainly in people who have significant trauma to the cervical spine, the upper cervical spine, that they may have abnormal melatonin release and an abnormal circadian rhythm. And this is, to my mind, has not been studied sufficiently in multiple sclerosis, and in particular people with high burden of lesions in the spinal cord. And lastly, this complex thing or interaction between sleep and fatigue. I mean, you all deal with many people with multiple sclerosis, and I deal with far fewer, but fatigue is an overwhelming problem in multiple sclerosis, and fatigue may have a whole host of different causes. I mean, things like inflammation may contribute to the feelings of fatigue. One of the interesting things is this idea of sleepiness. So people may have sleep deprivation, but may not complain of sleepiness. And this is because, and you'll find this if you talk to your friends and family, that some people seem to be able to cope with very little sleep, don't complain of sleepiness during the day, are in fact sleep deprived. When we measure their sleepiness or have measured their sleepiness, we find that they're excessively sleepy, but they seem to be able to tolerate it. Whilst other people, if they sleep for 5 minutes less than their 8 hours, it completely destroys and wrecks their day because they have to fall asleep. And this is true of all people, and it's probably genetically determined, our tolerance to sleep deprivation. But the importance here is that obviously if people have disturbed sleep and feel sleepy during the day, then we can have a very obvious connection with fatigue. And we may recognize that obviously if we treat the cause of their sleepiness, then we would improve their fatigue. What is not recognized, I think, was inadequately recognized, is I say that some people are able to tolerate quite disrupted sleep and won't complain of sleepiness during the day. And that disruption of sleep can have a profound effect upon fatigue. So people with obstructive sleep apnea may not complain of sleepiness, but they complain during the day of fatigue. And one of the things that I've increasingly found is that people who have disrupted deep sleep will often complain of fatigue during the day, whilst if they get adequate amounts of time in bed, may not complain of sleepiness. And we see disruption of deep sleep with things like obstructive sleep apnea, but also people with periodic limb movements overnight, which are prevalent and under-recognized in people with multiple sclerosis, tends to prevent people going from light sleep into deep sleep. And so people tend to be deep sleep disrupted and tend to then have more complaints of fatigue if they don't have complaints of sleepiness. And there's also another concern and worry about this, which is that, as I showed you earlier on, there's some evidence that biochemical pathways that contribute to neurodegeneration in things like Alzheimer's, but also in other conditions, may be affected by having a lack of deep sleep, where deep sleep may be necessary for the brain to clear itself of toxins such as beta amyloid and phosphorylated tau. So I really want to stop at this point, and we'll go on to the slightly more practical part, which will be Sophia's part. But sleep disorders are definitely prevalent and under-recognized in people with multiple sclerosis. And they're multifactorial with both direct and indirect causes. And that sleep disruption results in fatigue, sleepiness, cognitive problems, but also an increase in mortality, and also may have an effect upon the immune system. And that what we really need is improved recognition and treatment of sleep problems in multiple sclerosis. And there's simple things to put into practice, but there are things that could have a considerable impact on people's quality of life. And with that, I'd like to stop and thank you very much for your attention. And I think I'll take questions now about this section before moving on to the next.
So that was fantastic, Matthew. Really good overview. And I learned a whole lot of things about the... Hi, Karim's come with a question. Very enjoyable talk, thank you. Any practical tips to differentiate between fatigue and sleepiness in the clinic?
Yeah, so sleepiness is very easy. Well, we'll go on to the Epworth score. Sleepiness is the propensity to fall asleep. So when we measure sleepiness, we just ask people how likely they are to fall asleep in different situations. And that's very different from fatigue. So for me, for a sleepiness score is very easy. We use the Epworth score, we'll go over that in the next talk. It's a score you can carry out. You can even give people a little form to fill out even before the clinic, and you discover very quickly whether they're sleepy or not. But I would say that in all people who have fatigue, although they may not be sleepy, I would also look for disrupted sleep as a possible cause. Because I say there are people out there who seem to be able to tolerate considerable sleep disruption without being sleepy, but complain of fatigue.
So, I mean, Matthew, just to follow on Karim's, and you mentioned doing what I would call these screening questionnaires in clinic. Is there a simple one that would screen for sleep disorders to prevent a deluge of referrals to your sleep lab?
Yeah, so I'll come to that in Sophia's talk. There's some very simple questionnaires that, as I say, that I mean, the Epworth score is the one that we use all the time for sleepiness. There are problems with it, and we'll come to that. But it's a very simple screen just to find out whether people are sleeping. But usually just even asking about sleep and a simple question about, what time do you go to bed? Do you find it easy to fall asleep? When you wake up in the morning, do you feel refreshed? And then do you nap a lot during the day? I think that one of the problems, as I say, is that about a quarter of the population seem to nap during the day regardless. So just finding somebody that naps during the day is not abnormal, but if they nap in unfortunate or situations like during meals when they should be working, then fine. If they nap during Netflix shows, then that's just normal.
I mean, one of the problems we have in MS is the symptomatic treatments. A lot of our patients are on antispastic agents, baclofen, benzodiazepines, tizanidine. These are all very sedating therapies. So, the sleepiness in the day may be due to their medication.
Yeah, no, I absolutely agree. And there's also indications that some of the disease-modifying treatments as well may have an effect on sleep. There's good evidence beta interferon has an effect on, or can cause insomnia. So I think there's yeah, absolutely, and steroids have an enormous effect on sleep. And giving high-dose steroids usually destroys people's sleep for a few days. So I agree, a lot of these treatments do have an impact on sleepiness. But that doesn't mean that we shouldn't consider treating it or consider ways of treating it. And it becomes more difficult, as I say, with the multiple medications, as you rightly say.
I mean, the other thing that a lot of MS patients take is they take a lot of stimulants, for fatigue. So I mean, I'm not sure these things work, but amantadine and modafinil now is, a large number of our patients are on these stimulants. And I don't know if that contributes to the insomnia problem we see.
So it can do. So depending on when they're taking them during the day. I mean, for things like modafinil, I won't let anybody have them usually after 2 o'clock in the afternoon. So the doses we give for modafinil tend to be in the morning and then at midday. And if you take them later on, then it disrupts sleep. I mean, a lot of people self-medicate with caffeine as well. And coffee has a considerable impact on sleep overnight. And even when people say, oh, I can still get to sleep, there have been plenty of studies showing that, if you have a cup of coffee after 4 o'clock, it has an impact on the amount of deep sleep you have that night. So, caffeine, which we all use, can have a considerable impact and can worsen things like periodic limb movements and sleep quality. And often just reducing the amount of caffeine that people take can improve their sleep and also improve the way they feel.
I mean, the other problem we also have is alcohol misuse.
Yeah.
There's been quite a few studies showing that people with MS, I assume it's driven by anxiety, have a higher consumption of alcohol, which, as we know, disrupts sleep as well.
Yeah, absolutely. So alcohol is quite interesting because obviously if you take, and I've seen people who take alcohol to try and help themselves get to sleep, you know, they're trying to treat their insomnia. And of course, alcohol gets you to sleep very well, but the problem is it's got a very short half-life. So you get things like rebound REM towards the morning, and the other thing you see is quite disrupted sleep overnight. So you see very deep sleep after the alcohol, and then you get disrupted sleep in the later part of the night. And then when people are taking alcohol chronically, so they're drinking chronically, then they tend to have very disrupted sleep overnight, regardless. And the mechanisms of that aren't absolutely clear, but certainly it seems to be associated with that. And again, there's this interaction with anxiety. I think anxiety is I think it's the biggest problem in terms of sleep. I mean, anxiety is the thing that drives people to insomnia. And then once people have insomnia, they then tend to get anxious about the insomnia. And so it tends to maintain their anxiety surrounding sleep.
Okay. Okay, Matthew, two other questions quickly is, how would you assess cervical lesions causing sleep problems? Would you be able to pick that up with sleep studies?
No, so well, I mean, it's interesting. Because I was thinking about this when I was just thinking about the talk, which is about circadian rhythm disorders in people with multiple sclerosis. I don't think there's been a lot of work done on it. You could certainly pick out if people start to complain about insomnia. One of the things to find out is whether it's true insomnia or whether it's the fact that they are want to go to sleep very late. So there are two people who have insomnia. The people who just can't get to sleep, doesn't matter what time they go to bed, and then they can't stay asleep, or they wake up frequently in the night and then they feel terrible. They don't actually fall asleep during the day. And there's other groups of people with insomnia who just say, I can't get to sleep until 2 or 3 in the morning, and then I'll sleep through till midday the next day. And that's a circadian rhythm disorder. That's a delayed sleep phase syndrome. And so I think we should be looking for things like that, because those can be treated with phototherapy and with melatonin. There's been some controversy about whether melatonin is contraindicated in people with multiple sclerosis, which you'll know more about than I do. But certainly it would seem to me that we should be looking for those people with circadian rhythm disorders. So I expect probably quite a lot of people. It'd be a nice research project for someone. I think quite a lot of people with multiple sclerosis may well have those.
Yeah, I've seen a few of those in my career. I've had a few patients who've had actually documented sleep cycle reversal, phase shifts, one of them responded to melatonin and the other one didn't. I personally don't think the literature is convincing enough not to use melatonin in people with this disorder, in MS.
Yeah. And I think melatonin can work well. You need very low doses of melatonin for people who have circadian rhythm disorders. So it's the lower the dose, the better, really. And then light boxes can help a lot. And they tend to shift, if they have a light box in the morning, tends to shift the cycle backwards. So they tend to be going to bed earlier. But the other thing that you'd expect if people are having problems with circadian rhythm, the other thing you can see is completely disorganized sleep, where people just be falling to sleep, at 11 o'clock, and then the next time it's 3 o'clock, and they move through, they start falling asleep at 11, then it gets later and later and later as the time moves on, they tend to cycle. And those people, I have to say, are incredibly difficult to treat. It's a very difficult disorder to treat when people have disorganized circadian rhythms. But again, light box and melatonin would be the way forward.
And then the final question there before we move on to your next talk is Gabriella is asking about, with interferon beta and severe insomnia, what would you recommend? Stopping the treatment or switching the therapy, or
treating the insomnia?
Yeah.
So, I'm not in a position really to say what you should be doing with your disease-modifying therapies, but insomnia can be treated. So the best things to try and help people get to sleep are probably not benzodiazepines, which people tend to develop tolerance to, but very often some of the anxiolytic and sedative antidepressants. So we use a lot of things like trazodone and mirtazapine, seem to be very effective. And if people are anxious, then cognitive behavioral therapy works a treat.
Okay. All right, Matthew, let's move on to your next talk then.
Yeah,
thank you very much.
So, as I say, I'm going to be giving Sophia's talk. This is really talking about the management and diagnosis of people with sleep disorders. So really, this is about establishing if there's a sleep disorder at all, and then a little bit about the investigations and management. But the main thing is just taking a history about sleep and establishing what time people go to bed, what time they get up, whether they're napping during the day, how long it takes them to get to sleep. If you're concerned about their sleep or sleepiness during the day, we'll come to this, but there are other things to look for, which will be things like collar size, their BMI, and whether they're snoring. And then are there events at night that they're aware of? And also things like restless leg syndrome. And it's important to get restless leg syndrome separated from just this akathisia, the need to move. Restless leg syndrome is not just the need to move, it's that if people don't do it, it becomes painful and uncomfortable. And so they're driven to the fact that they have to move. And when they move, it stops. And then when they stop again, the symptoms recur. And it's important, again, to look for non-sleep related issues. So if you're going to take things that are common in multiple sclerosis, spasms, problems with nocturia, those are things that are going to be disturbing sleep, and those need to be addressed. And medication, obviously, which we just touched upon earlier, is important because medications can have quite a profound effect on sleepiness. And that may involve either changing the medication or substituting it, or changing the time of day, or adding in other medications that may try and address that. Anxiety. Anxiety, as I say, is one of the biggest drivers to insomnia and to sleep disorders. And asking about anxiety and depression, I think, are absolutely critical. So the score that we use all the time is the Epworth score, which I'll come to. There are other scores, and I'll talk a bit about the stop-bang score that can also be helpful in trying to screen people for obstructive sleep apnea. And then blood tests. When people have restless leg syndrome or periodic limb movements, I would do a ferritin in all people. And if their ferritin is lower than 75 micrograms per mil, then it would be important to supplement with iron. And then we have investigations, actigraphy, polysomnography, and multiple sleep latency tests, which I'll come to. So this is the Epworth score, and this is, it takes 5 minutes to do, and you'll be able to remember it. It doesn't take long to remember it. I can remember the score and do it instantly in the clinic. And it's really the chance of dosing during different situations. And with never dose 0 up to a very high chance of dosing. And you could do your score now, I should think, and work out how sleepy you are. And a normal score is 10 or less. And if people have a score of more than 10, then you have to start worrying about why is it that they're excessively sleepy. And really, when you start to get up to scores above 16, they certainly shouldn't be driving with an Epworth score of more than 16. And you need to identify why they're excessively sleepy and address that specific problem. The commonest cause for being excessively sleepy is having insufficient sleep at night. And that's going to bed too late and getting up too early. And again, that's why it's important or critical to have often a sleep diary if you can, but even just to ask them what time they go to bed, usually what time they get up. Now, there are pitfalls of the Epworth sleepiness score, that it's been validated in many situations, but it hasn't been particularly validated in multiple sclerosis. And you can get an underestimation or overestimation of symptoms. And the other thing is to point out is people can have quite disrupted sleep, again, to emphasize this, and yet have a relatively normal Epworth score, because some people seem to cope with sleep deprivation very well. There are people who also, there's recall bias, but there's also a bias about what people can and cannot do. So if you do an Epworth score and they get over 16, you say, well, I really don't think you're going to be safe to drive. They say, oh, could I redo that score then, please? And it comes in much lower. It's a subjective score, and they may increase their score or decrease their score depending upon what they want from the consultation. There's also a criteria for the diagnosis of restless leg syndrome. And really, this is the urge to move the legs or arms. It can occur in the arms. So people get restless arms, so it's restless limbs overall. It's relieved by movement, and that this relief is temporary, so that as soon as the person stops moving again, it comes back. And it tends to be worse in the evening and also at night. So there's another peak, usually about 3 or 4 in the morning. And things that would support the diagnosis are that there tends to be a family history of restless leg syndrome, although that may not be so in people with symptomatic restless leg syndrome, such as multiple sclerosis, but in people who just have it idiopathically, there's certainly usually a very strong family history, and it often shows anticipation with worse symptoms and earlier onset as you move through generations. It's associated with periodic limb movements of sleep. And the problem with periodic limb movements of sleep is that people may not be aware of the movements. So they're often maybe just very, very short little shuddering movements of the foot or leg that may be so slight that they may not be aware of it, but it's enough to disrupt sleep and sometimes to stop people getting into deep sleep. And partners or bed partners may not be aware of the little movements, may be aware of the slightly bigger movements and complain of big jerks that occur suddenly during the night, when all they're seeing is a more severe periodic limb movement. And periodic limb movements tend to occur every sort of 30 to 90 seconds, usually affecting the feet and the legs, but also can affect the arms, shoulders, and head. And there's a whole host of things when people are diagnosed with restless leg syndrome that we will look for. I mean, commonly iron deficiency. Pregnancy is obviously very strongly associated with restless leg syndrome. It's worth looking at glucose, thyroid function, and also UNEs. There are drugs that can be associated with it, in particular antidepressants, in particular the SSRIs associated with restless leg syndrome, and fluoxetine is often a culprit, worsening restless leg syndrome and periodic limb movements of sleep. And myelopathy as well, as can occur in multiple sclerosis, is associated with restless leg syndrome. And there's a severity score. This I don't usually fill out in the clinic, but it's a score where you can measure the severity of the restless leg syndrome. Usually you just need to know whether the restless leg syndrome is having an impact on their quality of life. And when it is, they let you know about it, because if you have bad restless legs, it is incredibly disruptive to your life. It's an incredibly uncomfortable thing. And people who have it severely are often, people don't think of it seriously enough. But I've seen people who've been almost suicidal because of the severity of it, because they cannot sit still. They're in my consulting room, they're walking around. They have periodic limb movements that disrupt their sleep overnight. And so it's important to ask about it and to treat it if it is having an impact on their quality of life. There's also the stop bang questionnaire, which is a very simple questionnaire. Again, it suffers in that it's not really been validated in neurological disease, for example, but it certainly gives you an idea. And many of the questions, I think, are questions that you should be asking anyway of people when they are sleepy during the day or fatigued during the day. So, do you snore? How often are you tired during the day? Do you often stop breathing, or people witnessing you stop breathing at night? And then high blood pressure is associated or strongly associated with obstructive sleep apnea. And then other things that are associated, having a BMI greater than 28, being over the age of 50, and having a neck size of over 17 if you're a man, or over 16 if you're a woman, is associated with obstructive sleep apnea. And being a man means you're at higher risk than being a woman. And you can work out with the stop bang score, you can give an estimate of whether people have a high, moderate, or low risk of having sleep apnea. And if there's a high moderate risk of them having it, then they should be investigated. And the investigation is often quite simple in that you can screen people with oximetry at home. The other investigations that we will often do, and again, actigraphy is something that's very straightforward, and this just involves having a watch. And indeed, many people now do their own actigraphy with their sort of Apple Watch or whatever. And it gives us a measure of the rest and activity patterns overnight. And there's a number of different algorithms that will work out whether people are asleep or not asleep. We can monitor light here in yellow, and we can see the person turn on the light here. And we can monitor movement as well. And we can then look to see when the sleep periods are occurring, how long they are, how efficient they are, whether there's movement in between, and at what time people are actually going to sleep. So you can see this person's got quite a variable bedtime and sleeping for, sort of 8-9 hours here, and here on the Sunday night, sleeping only about 4.5 hours. And so it gives us a very good idea of the sleep patterns people have. And the nice thing about it is that people have a belief about how they sleep, and often that belief is not accurate. So people will tell you that they go to bed regularly at midnight and get up at 7, or go to bed at 11 and get up at 7. And you find that often the sleep is like this, with insufficient sleep some nights and trying to catch up. And the thing about the insufficient sleep, again, it's mainly a problem of young adults, is that they think if you miss a night's sleep that you can catch it up the next night. And again, there have been studies, mainly in the armed forces, where they're very interested to know how long it takes to actually recuperate from missing a night's sleep. And it's about 2 weeks before you get back into your normal sleep pattern. So I tell people, if they're going to be changing their sleep, if they're trying to get more sleep, you can't just do that one night and then determine whether it's working or not. You have to do it over a period of at least 2 weeks to see an impact. And then in the investigation of some of these conditions, we will use polysomnography. So we don't use this for things like insomnia, but if we're concerned about people acting out their dreams, people having sleepwalking, people having periodic limb movements, or if we can't explain everything just by a screen for obstructive sleep apnea, can't explain the sleepiness, then they will get the full EEG, measuring of breathing with thoracic belts, oximetry, and also EMG, measuring movements of the limbs. And then we will do multiple sleep latency. We usually do this to diagnose people with narcolepsy, where people are given 5 chances to fall asleep during the day. And we look at the mean sleep latency and sleep onset REM. They're allowed to sleep for a total of 15 minutes. And if they have REM during that time, then they will, that's abnormal. REM onset is usually beyond that time. And if they fall asleep on average less than 10 minutes, that's abnormal. It takes an average 10 minutes for people to fall asleep during these multiple sleep latency tests, or more than 10 minutes. And once it gets below 8 minutes, we then think that's pathological. So we can take a sleep history. We've got some questionnaires, the ones we tend to use at Epworth, and I've used the Stock Bang as well. And then we're really just asking about whether people are sleepy during the day. And the management usually involves, in most people, just trying to get them into a good sleep habit. And people misrepresent the amount of sleep they'll have. So we ensure good sleep hygiene. You need to reduce daytime naps. So daytime naps should be less than 15 minutes. If it's longer than that, then we'll find that we often find that has an impact on overnight sleep. We need to consider underlying sleep disorders, in particular periodic limb movements and obstructive sleep apnea, which are common. Optimize medication, and then obviously treat non-sleep related disorders that may be having an impact on sleep, in particular things like anxiety and depression. I only have a few minutes, so I'm going to go through this quite quickly. Restless leg syndrome is to make sure that people have the diagnosis. We need to treat people with low ferritin with iron. We need to avoid some of the antidepressants, or consider changing the antidepressants that they're on. And then if people really are not sufficiently treated by these simple measure, then dopamine agonists, ropinirole, pramipexole, and rotigotine are licensed for this. Other things work incredibly well. Gabapentin and pregabalin can work very well in restless leg syndrome and periodic limb movements. Clonazepam can work well, but can cause drowsiness the next day. But also opioids, so even small doses of codeine at night can be very effective. And periodic limb movements are often associated with restless leg syndrome, occur in about 18 to 90% of people with restless leg syndrome. People can have periodic limb movements overnight that disrupt their sleep considerably without having restless leg syndrome. So even if people don't have restless leg syndrome, it's worth asking for disrupted sleep overnight for the observational or for periodic movements that occur through the night. And again, treated in a similar way to restless leg syndrome and exacerbated by similar medications, in particular things like antidepressants. Obstructive sleep apnea or weight loss. People are often much worse on their back. You can have mandibular advancement splints, so which pull the chin forward. They often help with the snoring. And those sort of things can help, but if people have moderate to severe obstructive sleep apnea, then they usually require CPAP. And CPAP can be life-changing for people. It can have an enormous effect, not only on their sleepiness during their day, but also feelings of fatigue. Very often I've seen people with obstructive sleep apnea who have headache and fatigue during the day, rather than overt sleepiness. And again, we need to consider stimulants for excessive daytime somnolence, which we use for narcolepsy, and we have good experience of that. Unfortunately, in multiple sclerosis, there's not a lot of evidence that stimulants are superior to placebo in improving fatigue. And I would say that for many people, it's important to try and differentiate fatigue from sleepiness and recognize that, you know, those sorts of drugs are very good at treating sleepiness, but may not be so good at treating fatigue, which has multiple other causes. Insomnia, cognitive behavioral therapy is incredibly useful, especially in people with anxiety. And we mentioned about hypnotics, and I tend to favor the antidepressants, trazodone and mirtazapine over benzodiazepines, because I think they're better tolerated and they have less of a hangover effect the next day. And CBT, as I say, involves educating people. It's often trying to reduce anxiety around sleep. And what tends to occur is that something may precipitate it, an event, even the diagnosis may precipitate insomnia. And then insomnia tends to maintain itself because people get anxious about going to sleep and the time around sleep. And in this time, when it's very difficult to get cognitive behavioral therapy, in fact, it's very difficult to get cognitive behavioral therapy when we don't have COVID, there are internet-based cognitive behavioral therapy for people with insomnia. And these have been tested in controlled studies and have been shown to be almost as effective as face-to-face cognitive behavioral therapy. And the one that is available for many people is Sleepio, which is available to some people within some CCGs, and is a very effective cognitive behavioral therapy program for people with insomnia. So sleep disorders may contribute to daytime symptoms. Really, I think the thing to do is to ask about them. It doesn't matter whether it's multiple sclerosis or Parkinson's disease or epilepsy, which is my specialty. Most people who deal with these conditions don't ask about sleep disorders. and it's important to identify them, to have an idea of what the cause may be, and then simple measures addressing those things that you may think are causing it. In particular, usually it's behaviorally induced, and get those treated. And if it doesn't improve, then to consider whether there may be other underlying conditions that you haven't identified, and to identify those may need referral to a sleep clinic, and for them to have further investigations. So thank you very much for your attention again.
There's one question that's just come up is, this sounds like a functional disorder. What would you recommend for someone whose sleep is disturbed, startled? Obviously gets startled, jumps out of sleep and sleepwalks, was not aware is the underlying cause.
Right, okay. So if it's a non-REM parasomnia, so that's where people will be sleepwalking and will not be aware, and they often get out of bed and walk around. That tends to occur in deep sleep in the first third of the night. And if that is the case, then very often some of the antidepressant type tablets, in particular things like trazodone, may be able to do that by improving sleep. What you have to be concerned about is that usually these non-REM parasomnias are caused by a disruption of sleep. So it's something that tends to rouse people. And what happens during a non-REM parasomnia is that the frontal lobes remain deeply asleep. So your ability to have social context and to plan is gone, whilst the limbic system wakes up. And so people often try and escape. So they'll try and run out of the room or jump out of the window. And then people often will go back to bed and be unaware of what they've done. People can do complex actions as well. So I've had people who've managed to clean their room or sleep eat as well without recognizing it, or cook. With certainly in multiple sclerosis, what you need to be aware of is, are they snoring? Do they have periodic limb movements, things that may disrupt sleep that may result in them having that? There's also, as Gavin brought up, there's also people who have functional disorders as well, but they're rarer. Usually these are non-REM parasomnias and usually precipitated by something. And if they're getting jumps or movements overnight, I would be concerned about whether they're having periodic limb movements. And sometimes treating that is sufficient to treat or prevent the non-REM parasomnia from occurring.
This particular patient is startled first before they have their parasomnia. That's very atypical, isn't it?
Yeah, it is. So I don't know what you mean by startled. I mean, usually when people have non-REM parasomnia, it occurs from sleep. They can have a little jump because that may be related to things like periodic limb movements or obstructive sleep apnea, and then they have their parasomnia and they're unaware of it. I'm not sure what you mean by startled, but
okay.
Maybe you want to clarify that.
Okay, well, we've run out of time, so Matthew, thank you. That is fantastic. I think this is just the kind of talk we wanted, just to raise people's awareness. As you're probably aware, this has been recorded and will go online for asynchronous viewing. And we often get many hundreds of views after the talk.
Okay.
So we'll almost certainly want to invite you back to give us some additional talks in the future. I hope you're up for it.
Surely. I mean, hopefully, when we get over this, it'd be nice to show some videos as well when we have time of some of these sleep disorders, so you can see what they look like and be aware of what occurs. And we haven't really touched upon things like the parasomnias and REM sleep behavioral disorder, which also can occur in MS.
Now, these when you say you send people home for their own pulse oximetry, is that your own device, or does it plug into a smartphone? It's one of those ones that Bluetooth.
No, so they have their own device and it just records with pulse oximetry. But people now can do it on their smartphones. And I have people coming in with whole loads of data that they've recorded with various devices they bought online. And one of the things is many of these things are not particularly well validated. And certainly in the past, a lot of the hypnograms that people used to come to clinic with, I think, were fairly inaccurate and certainly didn't reflect the ones that we used to record. But I think now they're getting better and better. And I think quite a lot of these hypnograms and things that people get from their smart watches and things are pretty good. And people can do it themselves.
Yes, I mean, I know that I had a student that reviewed the various sleep apps for screening for obstructive sleep apnea, and this was about 2 years ago, and at that time none had been FDA or EMA approved or CE marked,
Yeah.
at that time. I think things may have changed, but it's very hard to ignore a patient who comes to clinic when he with their partner, and their partner's recorded their snoring and the episode of apnea. So it's very hard to ignore that. So I think we need to take those personal recordings and self-monitoring quite seriously. I don't think we should dismiss them. I find it very difficult to dismiss them.
Yeah, no, I wouldn't. And as I say, I think in the past they were very inaccurate, but I think now I think they're getting more and more accurate and better. Those ones that tend to say whether people are in deep sleep, light sleep, or dream sleep are nonsense. But the ones just recording the amount of sleep usually are quite good.
Okay, thank you very much, Matthew. Thank you, everybody. Please spread the word that this is going onto the website as a recorded talk, and hopefully people will log in later on to watch it.
Okay.
Have a good evening.
Thank you very much. Lovely to see you.
Thanks.